The talk I gave was focusing on stroke in the elderly and what treatments work and which treatments may not work. And so we focused on four things primarily. Number one was the importance of atrial fibrillation in the elderly, and the fact that we have several medications which are proven to reduce the risk of stroke in the setting of atrial fibrillation, but they're underutilized in the community. And so despite numerous trials over the last 20 years and numerous studies, the primary care physicians and other physicians are still not using the medications appropriately. And some studies show that only 50% of AFib patients who should receive anticoagulants are actually getting those medications. So we need to continue to hammer home that message and think of innovative ways to try to improve the appropriateness of those medications. The second area which we talked about was carotid stenosis. And it's common in the US for patients to undergo surgery on the carotid artery even if they don't have symptoms, and that's called asymptomatic carotid stenosis. And so we mentioned that in the elderly, especially above age 75, it's very unclear as to whether they benefit from surgery. And so I recommended that as to the greatest extent possible, people should be referred to the CREST-2 study, which is a NIH study comparing aggressive medical therapy versus surgery or carotid stenting. And so that I think will be very useful for both our patients as well as clinicians. Yes, definitely, because for each decade that you go after age 55, the risk of stroke almost doubles. And because of the aging of the US population, it's going to be incredibly common in the next few decades. There are several anticoagulants, and so the oldest one was Warfarin, and then the newer ones, which are sometimes referred to as NOACs. Those include dabigatran, rivaroxaban, edoxaban, and apixaban. And so all of those medications have been shown to reduce the rate of stroke for patients with AFib. The challenge is still making sure that the appropriate patients get those medications to optimally reduce their risk of stroke. After 20 years of trying to hammer home this message, you would think it isn't physician knowledge. I think most physicians know that the medications are effective. I think what some physicians may not know is that they may not know that aspirin is not very effective in atrial fibrillation. And so we still see that in the real world about 20 to 25% of patients with AFib get aspirin. And I think I was co-author on the American Academy of Neurology AFib guidelines a couple of years ago, and one of the messages that we tried to convey in that document was that aspirin is not very effective for patients with AFib, and so clinicians shouldn't default to aspirin and think that they're optimally protecting patients. I wouldn't say it's the gold standard because it has a number of problems with it. The fact that it takes a while to kick in the system, it takes several days for the patients to get to a therapeutic level on warfarin. Also, it has a lot of interactions with other medications, interactions with diet, and it has a substantial risk of bleeding in the brain. And so the newer medications, one of their major advantages is that they have about a 50 to 60% decreased chance of bleeding in the brain. And so I think that's a key advantage. For the patients who have artificial valves, warfarin is still the recommended medication. And as you said, none of the new medications are approved for people with valvular disease, significant valvular disease. There was one attempted trial which looked at dabigatran in patients with artificial valves, but it wasn't very effective. And so I'm not sure whether other additional studies will be done in the future, but at the current time, warfarin is still recommended. That's another point that I made in my presentation over the weekend, is that a lot of our clinical trials are geared toward patients between the ages of 40 to 70 or 40 to 75. And so we need to, I think, develop some new studies focusing on which treatments are effective in patients above age 80, and also look at what outcomes are important to those patients. It may not be the same as what may be important to somebody age 50 or so. I think stroke in the elderly is a huge issue because, number one, it can lead to institutionalization or death. It can lead to cognitive impairment and a loss of independence. And we know that stroke overall is the leading cause of disability among adults. And so it's going to be a major challenge in the coming decades. I think it has to be a multi-pronged approach. We need to control the high blood pressure in elderly individuals to a greater extent. I think there needs to be broader use of cholesterol-lowering medications, and then, as I said, better use of anticoagulants.